Today we are gathered here for our 21st Physiotherapy Combined Round, which is on the topic case presentation for the management of pain through kinetic control exercise in a 26-year-old female with cervicogenic headache. And today we are collaborating with the Orthopedic Department of Mahatma Gandhi Medical College and Hospital. Over the period of these 20 PTCRs, we have seen many cases, and we have, in collaboration with many departments, we have worked towards a holistic care for our patients, and that's what we need to do furthermore as well. So today with us we have our speakers, Dr. Shreyansh Gupta. He's third year resident, Department of Orthopedics, MGMCH. Dr. Garvi Vats, PhD scholar of Mahatma Gandhi Physiotherapy College, and Dr. Nitin Kaushik, MPT Resident, Mahatma Gandhi Physiotherapy College. And the entire physiotherapy combined round is being held under the guidance of Dr. Ashwini Mathur sir, Professor and Head of Department of Orthopedics, MGMCH, and Dr. Lokesh Sharma, Professor, MGPC. Firstly, now I would like to call Dr. Shreyansh Gupta to share some light over the topic cervicogenic headache.
Morning to all. I am Dr. Shreyansh Gupta from the Department of Orthopedics. I will be talking about the topic cervicogenic headache. So it will be classified there are primary headaches and secondary headaches. Primary headaches consist of migraines, tension type headaches, and medication overdose headaches. And secondary headaches are symptoms of another pathology which present as headache. They include the headache caused by tumors, hemorrhage, trauma, cervicomandibular joint, referred pain, and cervicogenic headaches. Cervicogenic headache is a lateralized, non-shocking headache caused by nociceptive source in the cervical spine. They are chronic, recurrent headaches that usually start or aggravate after a neck movement and is usually accompanied by reduced range of motion of the neck. Relevant anatomy to understand cervicogenic headache: the cervical spine consists of 7 vertebrae, C1 to C7, and there are 8 nerves root in total, that is C1 to C8, along with the muscles and ligaments. The upper cervical vertebra supports the skull, and it is also known as the atlas. The atlas articulates superiorly with the occiput, which forms the atlanto-occipital joint. This is responsible for 33-degree flexion and extension, that is the yes movement over the skull. Below the atlas is the axis, which allows the rotation, the lateral rotation. The atlanto-occipital joint is responsible for 60% of the cervical rotation, that is the no movement. The 5 cervical vertebrae that make up the lower cervical spine, C3 to C7, are similar in nature but very different from the upper cervical vertebra, that is C1 and C2. To understand the etiopathogenesis, the cervical spine C1, C2, and C3 converge with the trigeminal nerve and form a nucleus which is known as the trigeminal cervical nucleus near to the brainstem. So any pathology at the C1, C2, C3 level would be referred to the nucleus and would further present as pain. The C1, C2, C3 nerve relay pain signals to the nociceptive nucleus of the head and neck, the trigeminal nucleus. This connection is thought to be the cause of referred pain to the occiput. Clinical features: the cervicogenic headache is a unilateral or unilateral dominant headache. It is exacerbated by neck movement or postures. The cervicogenic headache is associated with neck pain. On examination, there is tenderness of the upper 3 cervical spine joint, and definitive diagnosis is made through selective nerve block through local anesthetic injections. To diagnose, we have the cervicogenic headache international study group criteria to make our diagnosis. The first criteria being symptom and sign of a neck involvement, precipitation of headache by neck movement and or sustained awkward head position, and or by external pressure over the upper 3 cervical region or occipital region on the symptomatic side. The second criteria being the restriction of range of movement with the neck. The third criteria being ipsilateral neck, ipsilateral shoulder or ipsilateral arm pain of vague non-radicular nature, occasionally arm pain of a radicular nature. The next criteria being the confirmatory evidence is made by diagnostic local anesthetic blocks, and the third criteria being unilaterality of the neck pain without section. Investigation to make a definitive diagnosis, structural imaging such as MRI, which would help us rule underlying pathology such as disc degeneration, compensatory posterior ligamentous complex thickening, nerve root compression, and spinal canal stenosis. Method to confirm the site of nociceptive pain would be controlled local anesthetic at the site of probable cervical pathology. And third would be assessing echogenicity of neck muscles such as longus capitis, rectus capitis, and posterior major using an ultrasound. From orthopedic point of view, we would treat the underlying cause of the disease, which is causing the radicular nature of the pain. So the primary line of management for cervicogenic headache is physical therapy. The secondary being percutaneous interventional procedure, including anesthetic block, which would both be therapeutic and diagnostic. And third would be surgery, which main treatment would be treating the underlying cause. Most commonly, the cervicogenic headache may present due to listhesis, spondylolisthesis, that is still disc. So in that case, we would do a cervical decompression and non-fusion surgeries.
So the patient was a 26-year-old female who is pursuing a post-graduation degree from Jaipur only. The chief complaint she was bringing towards her was the pain in the neck, especially in the left side and in the cervical region since last 2 to 3 months. She was also complaining of disturbed sleep, difficulty in falling asleep, fatigue, low mood, stress-related aggravation of pain, and occasional anxiety and emotional withdrawal towards activity. Now the history of present illness was the mode of onset was inside her and gradually in nature. The duration of symptoms was around 2 to 3 months. Type of pain was dull edging pain. Location of pain was neck, especially the left region, and around the suboccipital region. The course of illness was continuous throughout that period, and the problem was deteriorating in nature. The aggravating factors were prolonged sitting on the computer work. The relieving factors were relaxation, rest, and hot fermentation. The intensity of the pain was 6 out of 10, which was using NPRS scale for vision. Consultation with orthopedicians was done. Investigation by X-ray and sonography showed negative results for any abnormality. The prescribed medication provided no relief. History of past illness. There was no such history of trauma or other injury. There was no such history of subsequent health issues. The patient reports of long hours, approximately 6 to 7 hours daily, of laptop use since last 1 year, because of which she has developed pain. Now the clinical exam. The body build was ecomorphic. Her gait pattern was normal. Her posture was mild forward-headed posture in the neck region, which was due to the prolonged sitting. The functional testing was she was facing sitting intolerance. Sleep was disturbed. She was facing participation issues and leisure activity was reduced. There was no wasting of the muscle, no edema, no scars, no tenderness, no temperature, no crepitus. The breathing pattern of the patient was shallow upper chest breathing pattern.
Disturbance of sleep and go back and reduced participation in study and leisure cannot be part of clinical examination. That is part of history. Did you keep her here till night and then see whether her sleep is disturbed? So there is a difference between history and examination. History is what the patient tells you. Examination is what you find. So sitting problems reduced maybe that you ask her to sit for some time and then find that she is not able to hold her head. The remaining two are part of history.
Now the radio motion. The flashing active cervical radio motion was normal and the passive radio motion was also normal and complete. The extreme cervical range of motion for extension was normal, and for passive it was normal and full. For right rotation, the active range of motion was normal and full. For passive it was normal and full. For left cervical rotation, the movement was slightly restricted and there was a presence of mild stiffness in the neck. The passive range of motion was normal. Now to the right sided section, both active and passive was normal and full. For left side section, both movements were normal and full. Manual muscle testing. So she was having in the deep neck fibula, the left side of the neck was having -4 and the right side was having 4 out of 5. The SCM sternum major natural muscle. In the left side it was 4 plus out of 5. On the right side it was 5 out of 5. The upper trapezius, on the left side it was 4 plus out of 5. On the right side it was 5 out of 5. In the levator scapulae it was 4/5 in the left side, 5/5 in the right side. In the cervical extensor it was 5/5 on the left side. On the right side it was 5/5. For cervical rotator it was 4 plus out of 5 and on the right side it was 5 out of 5. For the lumbar it was 4 plus out of 5. On the right side it was 4 plus out of 5. Now the sensory examination was touch, temperature, pressure, kinesthetic, all was intact and normal. The dermatomes, myotomes were completely intact. The distended reflexes such as bicep nerve, knee jerk, ankle jerk were all completely normal and symmetrical. The vibration and proprioception of the patient was intact with the bilateral upper and lower extremities. The special test performed was cervical flexion rotation test. The purpose of this test is to assess the C1, C2 at the SCS joint mobility and to help diagnose the cervicogenic atrophy. Technique was the first we have to perform passively cervical flexion completely, then we have to maintain the cervical flexion, then slowly we have to rotate the head towards the right side. Then we have to bring it to the neutral side while keeping the cervical flexion, and then we have to completely rotate the head to the left side. Then we will be raising the head to complete towards the neutral side and extend the head to the initial position. The findings of the test will be reproduction of the patient's physical headache pain. The patient was complaining about a certain pain and that same pain will be reproduced during this movement. And hard anti towards one side. Because in this case it is the left side. Now anthropometric measurement. The muscle volume was symmetrical and appropriate on both sides. Pain was 6/10, which was measured by numerical patient scale. Baseline outcome measures used were numerical pain usage scale, which is used to quantify the baseline headache and neck pain, monitor pain reduction after treatment. It is easy to administer and sensitive to short-term clinical change. Other outcome measure was used neck disability index, which is used to evaluate functional limitation due to cervical dysfunction, which is strongly correlated with cervicogenic headache severity. It guides treatment planning, widely used outcome measure in cervical patients. The MPT scale is 0 to 10, while where the 0 is mild and 10 is the maximum pain patient can. For functional disability, it is 0 to 50, where 0 is the minimum disability and 50 is the maximum disability. It can also be written in percentages and is used to identify neck functional disability.
Thank you, Nitin. As we move forward towards the treatment of cervicogenic headache and for this particular patient, I would like to request Dr. Garvi to come forward and tell us and enlighten our students about what kinetic control exercises are and how these can be helpful for the treatment of cervicogenic headache.
Respected This one is MPT and other faculty members. I'm Dr. Garvi Vats from a PhD scholar in Mahatma Gandhi College of Physiotherapy, and today I'll be talking about the management of cervicogenic headache via the kinetic control exercises. So, whenever we talk about the kinetic control exercises, it is very important to understand what are the movement dysfunctions. So, whenever any movement dysfunction in our body occurs, it usually leads to an uncontrolled movement pattern that is developed with the severity and the intensity about what intensity and severity of pain the patient is complaining of. And the other part is the disturbed range of motion. In a pathology, we usually find a reduced range of motion for the patient. Now, talking about the movement dysfunction, they can occur locally as a dysfunction of the recruitment and motor control of the deep segmental stability. That means, whenever we are talking about the spinal segments, the cervical or the lumbar or the thoracic vertebrae, there has to be a stability among the vertebrae so that we can train the patient for that stability, and the intensity of pain as well as a good control can be achieved for the patient. Secondly, we also have to talk about the global stability. Now, the global stability is usually responsible for the range of motion. So, as I discussed earlier, that we are talking about the stability of the segments as well as the disturbed range of motion. So, the stability comes when we are talking about the local muscle group, and the movement is usually achieved by we talk or when we train the global muscles of the cervical or the any spinal segment. It is important to identify the uncontrolled movement in the functional movement pattern. The uncontrolled segment is most likely the source of pathology and the symptoms of mechanical origin. So, the uncontrolled movement leads to an abnormal stress or strain, which leads to pain or pathology. When we are talking about any kind of therapy in physiotherapy, any exercise related therapy, any soft tissue manipulation or any kind of mobilizations, we are usually targeting this uncontrolled movement pattern. Now, if I talk about the movement system, it usually impacts the articular system, the myofascial system, that is the muscles and the fascia, the psychosocial influences. As Nitin already mentioned, that the patient was having an emotional intolerance and a disturbed sleep. That was because the patient was again having the psychosocial influences because of the pain. There is a connective tissue system and the neurogenic sensitization and the neural system. So whenever a pathology occurs, all of these movement systems are affected for the patient. Now, talking specifically about the kinetic control exercises, these involve the performance of movement with optimal interaction between the neuromuscular control, that is the sensory feedback and the central nervous system processing, as well as the motor coordination and the physiological stress. So we are not only talking about the motor imbalances that has happened with the patient, we are also targeting the psychological stress as well as the sensory feedback to the patient. The action should be performed with appropriate intensity and timing. The movement system requires coordination between different body systems, including the neural, myofascial, articular, connective tissue system, in addition to the central nervous system, psychological and physiological factors. Any problem in one or more of these systems will result in pain, dysfunction, and a compromised life activity. According to researchers, it has said that the proprioception relates to three key sensations, that is sensation of position and movement of the joint, sensation of the force and efforts, and sensation of the motor contraction. So if I depict these 3 points, I was having a patient with a forward neck posture, right? So whenever a forward neck posture occurs, that means that if my neck is right now in a straight position, in a forward neck position, it will go like this. Right? Now what will happen is, something that was straight has now gone in this position. What will it lead to? It will lead to the first one, that is a change in sensation and movement. That means, जो चीज ऐसे होनी चाहिए थी, with time it has gone to this position. That means the natural movement has been disturbed as well as the movement of the joint has happened. The joints which were intact by the nature, now because of the pain they have gone into this position. Secondly, there is a sensation of force and efforts. The muscles, those were responsible for maintaining the integrity of the joints as well as the stability in these particular joint segments. Now they have to put up some extra efforts to maintain the disturbed range of motion. Secondly, there will be a sensation of muscle contraction that will also happen because of the disturbed muscle alignment in these particular spinal segments. Moving forwards, we talk about the uncontrolled translation and the uncontrolled range. For uncontrolled translation means the uncontrolled movement pattern that has happened. We will be targeting the local muscle system. That means the muscles which are responsible for the particular spinal stability, as well as the global muscle system for the range of motion. Sight and direction of the uncontrolled movement will be checked and then it will be taken care of. And the last one will be the articular restrictions that can be dealt with the manual therapy, and myofascial restrictions that can be dealt with the with regaining the extensibility of the global muscle system, that is the big muscle group of our body. Now, because again talking about the local muscle group and the global muscle group, we all know that there are two groups of muscles in the body. One is the local group of muscle and the other one is the global group of muscle. One is responsible for stability and the other one is responsible for mobility. So, stability group of muscles, these are the local stabilizers. These are usually one joint muscle, monoarticular in nature. These are deeply present in our body, have a leverage of load maintenance, static holding and joint compression, and they are responsible for the posture holding in the spine. Talking about the mobility group, these are usually two joint group, muscles. They are superficial. They provide unidirectional fibers or tendinous insertions to direct force to produce any sort of movement. These are responsible for leverage, range of motion, and speed and joint distractions. Lastly, they are repetitive or rapid movement role and high strain and force loading. So whenever you are doing any movement with speed, the global group of muscles are used in that. Example for stabilizers can be external oblique or internal oblique, semispinalis, deep gluteus maximus and subscapularis. The example for mobilizers are rectus femoris, pectoralis major, levator scapulae, as well as the rectus abdominis. So all the big group of muscles are the global muscles and the smaller group of muscles are the local stabilizers. Now this is a diagram which again depicts the global muscle. You can see that all the muscles are big in nature and the local stability group is always small and they are present among the spinal segments. Now, talking about this particular patient, this was the protocol that I have used for the patient. These are some of the kinetic control exercises that I have finalized after assessing the patient. So my patient was called for 3 sessions for 3 consecutive weeks. That means alternate day sessions was given to the patient. I have done all the exercises in presence of the physiotherapist and the patient was not allowed to do the exercises on their own. The treatment started post-assessment according to the cervical control impairment test. Now what is the cervical control impairment test? This test will tell you that which group of muscle you have to target for retraining for the patient. Right? Now I have a forward neck posture patient. The patient has come with a forward neck posture and the patient's complaint was headache along with some sort of stiffness that was felt in the left side rotation of the neck. Right? So whenever a patient is coming to me with a forward head posture, I know one thing, that the patient will be having tight upper cervical as well as the tight cervicothoracic joint, but there was increased movement in the mid-cervical region. Right? So that was my cervical control impairment test in which I have localized that what was the issue with the patient. According to this assessment, I have designed these exercises. So the first exercise, that is the low cervical flexion uncontrolled movement. So the lower cervical, that is the cervicothoracic joint, was again in flexion. The patient was like this. So the lower cervical was in flexion. The next group of muscles was the upper cervical extension. Now, if I'm supposed to be like this, I cannot, look at the laptop or I cannot do my work in this position. For that, what I will compensate is my upper cervical will eventually go into extension. So I will be standing like this, right? So upper cervical extension, that was more of extension जो naturally होता है उससे ज़्यादा extension हो रहा है upper cervical में. So I had to target that group of muscles And the last one was the mid cervical hinge. Now because the upper cervical is tight, the lower cervical is tight, what will happen to the patient is, patient ज़्यादा से ज़्यादा use करेगा mid cervical area को, right? So mid cervical hinge या जो range of motion है mid cervical region में वो बहुत ज़्यादा बढ़ जाती है. तो मुझे करना क्या था इस पेशेंट के साथ? I had to increase the movement in the upper cervical and lower cervical, and I had to regulate the movement in the mid cervical region. For that, I have finalized these exercises. So depicting my first exercise, that was occiput lift. That was for the lower cervical flexion. So for that, what we usually do is, if the patient is in this position, I will ask my patient to go for a chin tuck and then try to lift the occiput up like this. So what will this do is, this will increase the movement in the cervicothoracic joint area, that is the C7 and the T1. So C7 T1 पे हम लोग movement को बढ़ाने के लिए ये particular exercise लगाते हैं. Next is thoracic flexion. For that, again what we do is, we ask the patient to put a hand in the sternum regions. We will ask the patient to tuck chin and go for only upper thoracic flexion, like this, right? The next one was shoulder flexion overhead. For that, what we usually do is, we will ask the patient to stand along the wall, tuck chin and try to raise the hand up only till any uncontrolled movement is felt in the cervical region. What usually happens is, whenever a patient is having cervical instability, what the patient does is, the patient will lift the shoulder up like this, and after a particular range, the neck will go in this position and the shoulder range of motion will be achieved. So for controlling this uncontrolled movement, what I asked my patient was to stabilize the neck in a chin tuck position and then lift the shoulder up only till there is no additional movement in the cervical range. With time, when the stability increased in the mid-cervical region, the range of motion for shoulder was also achieved. The second one was the upper cervical extension. Now again my patient was in hyperextension in the upper cervical region, so I had to control that. For that, I asked my patient to go for a head backward lift. That means in a chin tuck position, the patient was asked to focus on the head region and try to look up like this. We do nodding, so that was a reverse nodding in this position. And the last one was the mid-cervical hinge. For that, I asked my patient to focus on the chin. In a chin tuck position, ask the patient to go for a chin lift. Fine. So these were the 3 set of exercises which I prescribed my patient. I have a few images of me depicting the exercises for the patient. In these exercises, you can see a particular instrument that I used over here. This is a pressure biofeedback instrument. So what usually happens is, whenever a patient with such issues come to us, it is very difficult to demonstrate these exercises to the patient, and to measure whether the patient is doing it correctly or not is again a task. So for that, we usually use a pressure biofeedback instrument. In this instrument, what we do is, we apply the instrument like this. You can see in the first image, I've put the instrument below the neck of the patient. I've maintained one particular pressure in this particular biofeedback instrument and asked my patient to do the neck movements without changing the pressure in this particular instrument. Right? So this is one of the aids that we can use while you are demonstrating the kinetic control exercises to your patient. Now, the result analysis was again used by HIT, that is the headache impact test used for intensity of headache. It has scores that says 6, never, the patient never had a pain, 8 states rarely, 10 states sometimes the patient will say sometimes I'm having headache and sometimes it's not present, 11 says very often pain is there, 13 says it's always. Scores which are more than 60 will indicate a severe life impact. So again, the second instrument that I have used for the result analysis was a Kinetic software to calculate the craniovertebral angle. Because we are talking again and again about the forward neck posture, we have to see that whether these kinetic control exercises are also helpful to maintain the forward head posture or not, or to correct the forward head posture or not. So for that, I have used a software which will tell whether the patient is having a change in the forward neck posture. So according to the results, HIT6 pre-test was 64 reading for the patient, and post-test it was 51. And CVA was initially, when the patient came to me, it was 45.25 in reading, and post-test it got to 50.9. So that was some of the references again which I have used for making this protocol and using these sanity controlled exercises for the patient. That's it for today. Thank you so much.